Alright, hi guys, my name is Jordan Goodman Taggert. I am in the COMM 201 class for Western Carolina University. We had to do an informative speech, so I decided to do mine on hemorrhage control since it goes with the skills that you guys are doing today. This is a brief introduction of hemorrhage control. Now please note that this is only going to address two types of hemorrhage control. There is two more. These are two most common. Very rarely, the other two are elevation and pressure point. Putting pressure on a pressure point. Very rarely will you see those used. Usually you're either going to be able to stop the bleeding with direct pressure or you can use a tourniquet. So, any questions before we start? Alright. So, what would you do if you had a patient, family member, friend bleeding to death and you were their only hope? It's a scary thought, but it's something, especially if you're going into emergency medicine, it's definitely something that you need to think about. Alright, so according to the National Trauma Institute, after traumatic injury, hemorrhage is responsible for over 35% of pre-hospital deaths and over 40% of deaths within the first 24 hours. Second only to rates of death due to severe injury from the nervous system, which would be like a massive brain injury. Alright, so hemorrhage is responsible for a lot of deaths in the U.S., which is why this is an extremely important topic and an extremely important topic that we need to address in your basic class. So, during this presentation, like I said, we're going to talk about two methods of hemorrhage control, the two most common methods, which is going to be direct pressure and use of a tourniquet. There are two more, but like I said, very rarely will you go to those. Usually, if you can't stop at direct pressure, you're going to end up having to roll to a tourniquet, okay? So, again, two most common methods, direct pressure and tourniquet. Alright, so direct pressure indications. 9 times out of 10, and you'll see a slide coming up that was actually from the National Trauma Institute, where it actually talks about 9 times out of 10 you can stop the bleeding with direct pressure. Okay, so it's from capillary bleeding. We take a finger stick, and they've got the capillary blood from where they're still bleeding from it, and we hold pressure on their finger to make it stop bleeding. We'll do it with Band-Aid or 2x2. So anything from that to a small arterial bleed, okay? Don't think just because it's arterial bleed that it has to have a tourniquet, all right? And we'll kind of address that later on when we get to tourniquets, all right? So from one of my sources, this was actually from EMS1. The direct quote from them was, after packing as much gauze and more into the wound, apply very firm pressure for at least 3 minutes. Sometimes you may have to end up doing more. This quote says specifically 3 minutes. The combination of gauze packed into the wound and more direct pressure will stop bleeding in almost every case, okay? And that was an article that was published at EMS1, and I think it was February 23rd of 2016, so, you know, a week and a half, almost 2 weeks ago. Alright, so there's two ways to apply direct pressure. You can do it manually, or you can put the dressing on and then later wrap an ACE bandage and let the ACE bandage hold the pressure for you. So if you're going to do it manually, if you get there and somebody's already put a dressing on the wound, don't take the dressing back off, okay? Leave the dressing on, especially if you can see that there's some significant bleeding underneath, okay? What it is when you put the dressing on the wound, the body starts to immediately coagulate, okay? The blood starts to coagulate. It's trying to cause it to clot off, right? If you pull it off, you run the risk of exposing that, and whenever you do, you run the risk of pulling some of the clot that's already there, and when you pull that off, it's going to start it to bleed all over again, okay? So if it's already dressed when you got there, do not remove the dressing, all right? If there's nothing on it when you get there, apply a sterile dressing. We don't want to introduce any outside infection, okay? This patient's already having enough issues with the hemorrhage that's going on. Don't just go get anything. You have sterile trauma dressings that'll be on the truck. Use a sterile trauma dressing to put on these, okay? Once you put it up there, if you've been holding pressure for a few minutes and you see that it's starting to bleed through that dressing, get more dressing, okay? Keep holding pressure, but as long as you can see that it's slowing the dressing, direct pressure should be sufficient, all right? So, this is how to do it with the ACE bandage wrap. So, this is mainly applicable to extremity injuries. What you would do is you would do the same thing, hold your direct pressure, and if you can see that the bleeding is slowing, it's not soaking through extremely fast, but you know, you can tell that it still needs some pressure on it, you can get an ACE bandage wrap, just like you see. They'll wrap the sports injuries, it's kind of the rubbery, long, elastic bandage. You can get that and you can wrap it around the extremity to hold the dressing in place. What it'll actually do is it'll keep the direct pressure on the injury, and it'll kind of free up the hands of the providers, which is what's wonderful about an ACE bandage wrap, okay? As long as that's sufficient. If it's a more serious bleed, you may have to continue holding manual pressure, because obviously I can lean on something and hold more manual pressure than I can with an ACE bandage wrap, all right? Make sure when you're doing the ACE bandage wrap, make sure you check for distal pulses. All right, we're not trying to cause a tourniquet effect. We're going to talk about tourniquets in a minute. We're not trying to cause a tourniquet effect. So once you put that dressing on, you need to make sure you have distal pulses. So if I'm putting the bandage here and I'm wrapping the ACE bandage, distal to that injury would be further away from my body, so we would check a radial pulse, right? If it's, depending on how high up it is, we could even possibly try checking a brachial, okay? So, moving on to your tourniquet, indications for your tourniquet would be an extreme arterial bleed. Now this arterial bleed, I'm talking about, obvious spurting red blood, which we know is arterial. If it's oozing and it's darker red blood, we know that's venous, okay? So that's something that you need to remember, because you'll see it throughout your entire career, any hemorrhage test that you take, okay? If it's spurting red blood, that is an arterial bleed. If it is oozing a darker red blood, then that's going to be your venous bleeds, okay? So, if all attempts at controlling the bleeding have been unsuccessful, they're still bleeding continuously, or if you walk up and your patient's already showing signs of shock, which we know are tachycardia, cool clammy skin, agitation or anxiety, if your patient's already showing some of those signs and you can see that it's a spurting red blood, go ahead and do the tourniquet, all right? Now, understand, if my hand's cut off, we know that the arterial bleed is probably from the ulnar artery and the radial artery, right? So, if my hand is cut off here, don't tie the tourniquet up here, okay? You want to tie the tourniquet just proximal to the injury. Everybody with me? All right, we don't want to tie it distal, because if you tie it distal, you're wasting your time. All right, then the bandage needs to, or the tourniquet needs to go between the heart and the injury. Just think of it that way, okay? So if they've cut their hand off, or even if they've cut the arm off here, tie the tourniquet here, okay? You want to go up about 6 to 7 inches from where the injury is, because you don't want the tourniquet to slide off of the end of the amputated extremity. Everybody with me on that? Okay. All right. So contraindications for tourniquet use. One would think that I wouldn't have to put these up here, but unfortunately you do. Okay. If you walk in and my carotid artery is severed and it's spurting blood across the room, we're not going to walk in and tie a tourniquet at the bottom of my neck, right? Everybody with me on that? Like I said, one would think that I wouldn't have to use this, but there's a reason that it's on the slide, okay? So the neck, the thorax, abdomen, you're not going to be able to tie a tourniquet there, okay? Your best bet there is going to be to hold direct pressure and get them to a trauma facility as soon as possible, okay? Any questions on that? Okay. Another contraindication is bleeding that can be controlled with direct pressure, which we've already kind of addressed to a certain extent, but if you can control with direct pressure, do not put a tourniquet on it, okay? And we'll talk about why in just a few minutes. All right, so how to apply a tourniquet. So with a commercial device, just follow the manufacturer instructions, okay? I don't want to sit up here and teach you how to do one specific commercial device, because as soon as I do, you'll have 3 other kinds on your truck and you will not carry that one, okay? So if it's a commercial device, just follow the manufacturer's instructions. The cons to using a tourniquet is the accessibility and the inadequate training, all right? So tourniquets are kind of hard to get to sometimes, so we need to be able to get to them fast, which is why sometimes we have other items that could be a little bit easier for us, all right? So tourniquet can be applied by using a strip of cloth, or a strip of clothing. You can get it, just tie it proximal to the injury, tie it there until the bleeding slows, okay? If you don't have that, you can always use a blood pressure cuff. If you can fit a blood pressure cuff, so if their bleeding is here, if you can put a blood pressure cuff here, put it here, pump it up, and leave it, okay? Make sure the bleeding has slowed, all right? So this is just consideration. All in all, this is a peer-reviewed article where they use tourniquets in upper limb extremity surgeries, and pretty much what they said there was, the problem with tourniquets, once you put that tourniquet on, you cannot take it back off. If you take it back off, any blood that is sat down here in the bottom of the arm is starting to coagulate and starting to clot. If you take it off, you run the risk of those clots going back to the rest of the body. Everybody with me on that? Not to mention, you're also causing ischemia because now the rest of the arm is not getting the oxygenated blood, which is why if their hand is cut off, you don't want to put the tourniquet here, because in the event that they do have to end up amputating that arm, they're going to have to amputate it up to where you put that tourniquet on, okay? So you want the tourniquet as close to the injury as possible without it coming off the end of the extremity, all right? So summary, assess your patient, identify the best method of hemorrhage control. There's not one specific hemorrhage control that's going to work better or that's going to be used for every single patient. There's not a blanket hemorrhage control, all right? There isn't textbook answers to every situation because unfortunately our patients don't read the textbook. They don't know how to be that textbook patient for us, okay? So one day you could be the person that becomes the deciding factor as to whether the victim lives or dies. Think wisely, act fast. In emergency medicine, you don't get second chances, all right? We don't get takebacks, we don't get second chances. We do what we do, and then we try to learn from any mistakes that we made when we move on from there, all right? These are the references that were used, the National Trauma Institute. The very bottom one was the peer-reviewed article, and then the very top one was the EMS one. Any questions? All right, thank you guys.